Hi, I'm Dr. James Amos. Once again, this is a Dirty Dozen, this time on the Introduction to Consult Liaison in Psychiatry, and I'm indebted for these dozen slides in terms of some of the material on them to the Academy of Psychosomatic Medicine, specifically the Academy of Psychosomatic Medicine Resident Education Curriculum and the APM Health Reform Toolkit to promote psychosomatic medicine. You can see and learn more about the Academy of Psychosomatic Medicine at www.apm.org. So as usual, I've got a dozen slides that I'm going to go through rather quickly, and to get the most out of this presentation you probably would do well to go to my website, the practicalpsychosomaticist.com, where you'll see the slide set and some annotations. The way I'll do this is the way I usually do it, which is to stay on track by following along with the slides here. And the first slide after the title slide is a slide about the historical note, a historical note on CL psychiatry, and you can read that. It has a quote by Dr. George W. Henry, who is the author of Some Modern Aspects of Psychiatry in General Hospital Practice, which was written in 1929, and many of the points that are bulleted on this slide are relevant even today. And a favorite saying of mine that I've included on my website is from his paper, "Relegating this work entirely to specialists is futile, for it is doubtful whether there will ever be a sufficient number of psychiatrists to respond to all the requests for consultations. There is, therefore, no alternative to educating other physicians in the elements of psychiatric methods." The next slide is about the subspecialty of CL psychiatry, which some call a supra-specialty, but the reason for that is that it seems to encompass many knowledge and clinical skills relevant to general internal medicine as well as psychiatry. And it's a clinical service which is the practical application of the knowledge base of psychosomatic medicine. The Academy of Psychosomatic Medicine, once again, has some excellent resources for research and training in the subspecialty, and there are some URL addresses for you to navigate to in order to learn more about it. The next slide is about CL psychiatry models. There's a traditional sort of reactive model that most of us are used to, both in academic medicine and in community practice, and it's hospital or ambulatory care based. It's consultation upon request, and it's generally funded by fee-for-service. The primary responsibility for the patient still rests with the consultee, and then there's another model called liaison, which we don't see much of nowadays. It's not fee-for-service funded, and it usually means co-location within the department that the psychiatrist is serving. It's education intensive, and there's more emphasis on proactive case finding. This is rare nowadays, as I mentioned, and I'll have more to say about proactive case finding in a bit. There is shared accountability for the patient in this model. Next is the integrated CL psychiatry model, which is becoming more and more emphasized. It's hospital or ambulatory based. Again, it's a team-based model, and it's a modern concept in which proactive case finding approaches are conserved from the liaison model. And then there are some programs which are disorder specific, such as for delirium prevention, which I'll talk about briefly. The next slide has a little more information about the distinction and comparisons between integrative and what I like to call hit and run consultation liaison models. The integrated model is more collaborative, and collaboration is in a specified multidisciplinary team, both mental health and non-mental health. Psychiatrists and other physicians, psychologists, social workers, nurses, case managers, and support staff work together in a more or less specific, formalized way. The elements of integration include a mission that includes high-quality care for mental health problems in a non-mental health setting. The target population are patients at the center of the team-based model, of course, and the location is usually in a medical setting. Communication is through team meetings or by shared electronic health record or other means. The administrative duties are shared between the mental health and non-mental health staff, and fiscal integrity tends to be maintained either in an integrated mental health and non-mental health budget or in separate budgets. The hit-and-run model, on the other hand, which I've been working in for the last 17 years, is sort of a one-person operation with trainees in an academic setting, in my situation, or solo in community settings with informal yet genuine collaborative connections. Now, they may not be as formalized as they are in larger systems where integrated models are more customary, but they can work very well nonetheless. You can be allied with a non-mental health team, albeit in a less formally connected way. And some of these elements that you see in integrated models can be similar across hit-and-run and integrated models. The staff of integrated versus non-integrated CL programs is important to consider. Integrated programs generally are associated with a larger staff complement, meaning that there's usually more than one full-time equivalent on the service at any one time, or full-time equivalent is shortened to FTE. And there are higher numbers of total consults and follow-up visits. There are higher numbers of consults per hospital bed, and there are higher numbers of consults per FTE CL psychiatrist, yielding, we hope, greater efficiency and earnings per position. They tend to be associated with academic medical centers as well. Well, why all of this emphasis on integrated consultation liaison programs? Well, it's important to talk about the increased cost that psychiatric illness incurs in general hospitals. So there are 26 international and American studies that show that psychiatric comorbidity leads to increased utilization of hospital services, increased length of stay, increased costs, and increased numbers of post-discharge emergency room visits, more or increased rehospitalization rates, and increases in post-discharge medical utilization and costs. So just from a cost standpoint, there needs to be a greater emphasis on collaboration between psychiatry and general medicine and surgery, and this is one way that integrated consultation services can be important in adding value to our patients. So some of the advantages to an integrated CL service are that in terms of the proactive early screening, this can increase the detection of mental disorders by a factor of 10 as long as the medicine services are contacting consultants early in the course. The timing of consult requests accounts for about 11 to 12% of the variance in the length of stay. So the earlier psychiatric consultants are called, the more we can make a dent in the length of stay. Earlier detection reduces length of stay. On the other hand, we need to consider the workload on most psychiatry consult services, which tend to be hit and run and one-man operations. There's a limited manpower to address the increased volume demand in addition to the usual other requests. So while it's ideal to do case finding proactively, there tend to be lots of other unpredictable consult requests, as well as the sometimes unnecessary requests made by the primary teams. The CL psychiatrists in some of the studies that looked at the questions of early detection, reducing length of stay, the CL psychiatrists did the screening in most of those studies, and it was a labor-intensive task. More staff education might cut down on some of the unnecessary consult requests. And there's a link to one of my blog posts about unnecessary consult requests, which is kind of comical, and you might enjoy that. Now, there are many ways to approach the question of how to put together a useful, practical, and safe and cost-saving intervention like an integrated CL program. One of them is for delirium prevention. An integrated program can be coupled with a surgical team, for example. One of the studies that looked at this used dexmedetomidine for cardiothoracic surgery, and that study showed that the incidence of delirium was reduced from 50% to 3%, and also reduced length of stay. This was a study by Dr. Jose Maldonado out of Stanford, and it was published in Psychosomatics in 2009. Another study looked at preoperative olanzapine, prophylactic antipsychotic, in hip fracture repair. And this study, which was published by Larson and colleagues in 2008, showed that you could reduce post-op incidence of delirium from 40% to 14%, and increase the rate of discharge to home instead of to care facilities. The caveat about these particular types of models is that there are more studies needed before we can recommend routine drug prophylaxis of delirium. And then again, dexmedetomidine is not a psychiatric drug. However, psychiatrists are probably in a better position to advise non-psychiatrists about the use of antipsychotics in managing agitation, hallucinations, and other behavioral disruptive interferences with managing medical problems and keeping people safe in a hospital. There are non-pharmacological methods of delirium prevention that are very effective and have been shown in numerous studies to reduce the length of stay and prevent delirium. Lots of manpower capability is necessary to make those programs work, and they may be difficult for most hospitals to implement, although not impossible. This type of situation argues for an emphasis on the educational skills of small consultation liaison psychiatry services to encourage med-surg teams to explore implementation of their own delirium prevention programs. They don't necessarily have to be led by a psychiatrist, although psychiatrists are very effective team collaborators. The other question is how to do a better job with overdiagnosis and underdiagnosis of depression in the general hospital, and that's a focus that integrated consultation liaison psychiatric services could address. Underdiagnosis is a problem. Only about 13% of untreated depression in the general hospital have antidepressants initiated while in the hospital. Now, the caveat to that, of course, is that if a consultation and liaison psychiatrist is not going to see a patient in follow-up, or there is no opportunity for the psychiatric department with which the CL psychiatrist is affiliated to see the patient in follow-up after an antidepressant is initiated in the hospital, it raises questions about whether or not that's a safe discharge plan to, for example, for me to initiate an antidepressant and then never see the patient again. There are real questions about whether that's a safe discharge plan, or whether that makes any sense, or whether that's even responsible. So that may be one reason why antidepressants are not initiated in a general hospital by the CL psychiatrist. Depression in a hospitalized patient often becomes chronic and can persist after discharge. Only about 11% of untreated depressions will begin treatment during the year after discharge. It increases the risk of rehospitalization, and it can increase the risk of comorbid medical illness such as coronary artery disease and diabetes mellitus. Now, overdiagnosis of depression also occur, and many consult requests for evaluation of depression reveal subsyndromal depressions that are the result of bereavement or adjustment disorders and demoralization, which may not respond as robustly to antidepressants, may be more responsive to psychotherapy and other evidence-based psychotherapies. There are some risks associated with use of antidepressants in the medically ill, and they include prolonging the cardiac conduction time, which may lead to potentially life-threatening ventricular arrhythmias. They can also be associated with upper GI bleeds, and in certain populations can be associated with metabolic disturbances such as hyponatremia, for example, from the syndrome of inappropriate ADH hormone. The other thing to remember is that a recent survey revealed that depression can be overdiagnosed and overtreated. Now, that was the result of a recent U.S. survey published in Clinical Psychiatry News in June of 2013 or July of 2013, very recently, and it showed that depression was overdiagnosed and overtreated. The study looked at whether patients identified by their clinicians also met the DSM-IV criteria for 12-month major depression, and out of over 5,600 patients with clinician-identified depression, only about 38% met diagnostic criteria for major depression. So it's important to look at both sides of this issue about what the role of consultation liaison psychiatrists is in a hospital setting. I think it's important to realize that depression can be both underdiagnosed and overdiagnosed, and I think psychiatrists can help with that. The next slide is about how CL services can add value. Integrated or non-integrated CL services can improve quality of care and lower costs by decreasing the incidence of delirium through promotion of delirium prevention programs. They can contribute to the rapid detection and treatment of mental disorders and assistance in managing the agitation of delirium. They can also assist in rapidly transferring patients with mental disorders who are displaying unsafe behaviors off med-surg units to more controlled settings such as psychiatric units. And we could also help after that with coordinating transfer to outpatient care. So the last slide is a slide of references and resources, and I hope you enjoyed that. If you have any comments or questions about this presentation, please feel free to add your comments to the presentation on my website, thepracticalpsychosomaticist.com. Thanks very much for listening.